All right. Welcome to Planetary Health First, Mars Next. My name is Michael Mann. I'm the host, and we have Ben. I just go by Doc. What's up, Doc? We got Doc with us, and we got Sarah, and they're experts on all things. Well, actually, Doc is expert on all things, right?
Yeah.
Not and Sarah, but not me. Okay. No, but anyway, this is great. So anyway, we're going to have some good conversations today about addiction, medicine, and sort of where is their place, hopefully, with psychedelics in that. So I'll stop because I got to stop because I'm getting us in trouble. So you guys go ahead. I'm just going to get off the stage. How about that?
Are you leaving?
Are you leaving?
No.
I just want to point out that my nickname is Doc and that Sarah is an actual doctor. And that qualification should probably be pointed out repeatedly throughout this conversation as we talk. She would be the responsible adult in the room at this point.
I think you are, Doc. I really do. So thank you for creating some quorum, should I say. Anyway, but this is Tuesday. I'm wearing a shirt tribute to Basquiat, 27 years old, one of my favorites of all artists, and he died of a substance abuse, heroin disorder. So not only do I love this shirt, but maybe I can bring it back to reality here. So Dr. Oh gosh,
Matousek.
Can you start us off? Can you bring us back to reality with what we're talking about today? I want you to take the floor, please.
Sure. I will take the floor. Although I think Ben knows a little bit more than I do about all of this. So I pepper in with my neuroscience background. So I'll tell you who I am. Maybe that would help. My name is Sara. I am a neuroscientist by training. Then I went into public health, and it is time now, 12 years later, for those two worlds to come together, which is really exciting. The last couple of years, I was sort of in transition, trying to figure out what I'm going to be when I grow up. And so what I ended up doing was moving back into academia. As you can see, I'm at Gonzaga University now. I'm on both the neuroscience website at this university, but I am on faculty in the public health department, which is perfect. And we are in talks about launching a center to do community impact research efforts in collaboration with partners. That has a rigorous research component to it. And I have way too many ideas, and I'm really excited about a lot of them. But one of the big ideas is to potentially bring some research in psychedelic-assisted psychotherapy to our region. There's some of it going on. We call it the west side of the state. I live in Spokane, Washington. If you know anything about NCAA basketball, you might know Gonzaga, but you probably don't know where it is. It's on the eastern side of Washington state. We're almost in Idaho. It's a little blue dot surrounded by a lot of red. It's a really fascinating place to live. And but most of the scientific research, there's a lot of science over here on the east side. There's Washington State Universities over here. We've got University of Washington has a med school. I also work there. It's actually down the hall. That's just one of their campuses. But not a lot of sort of rigorous academic research happening. Most people go back to the west side, to Seattle, for that. However, Gonzaga University is interested in launching public health this year, and we want to do some research. And Ben and I have known each other for more than 20 years.
Yeah, long time.
Yeah, really long time. And sort of our paths sort of separated for a long, long time, and then kind of came back together because we're both interested and passionate about, the subject of mental health and substance use. And there doesn't even seem to be, there is incredible data backing up the fact that psychedelics in general and in combination with assisted psychotherapy is incredibly effective for substance use disorder, for PTSD, for a number of different mental health issues. And even last night, we had a healthcare roundtable meeting here on campus on the opioid crisis. Just last month, the city of Spokane declared an emergency because it's a small city, but upwards of 12 to 14 overdose incidents that required our first responders to respond per day in the first 2 months of the year, which is probably triple to quadruple what it had been. And it just seems to be getting worse and worse. So the head of the fire department was there. We had, our health commissioner. We had folks with family history. It was a really great group of people. And then all of the researchers were in attendance. And we had a good conversation afterwards at the networking event about potentially bringing in some support to build psychedelic assisted therapy for this issue. And I have the business card right here of an organization that is interested. And so we want to talk today a little bit about like where it could fit in a more general public health model as one component of sort of a multi-system collaborative approach to solving these problems. It's not, there's no silver bullet, and psychedelics is not that silver bullet, although they're pretty fucking effective. So
Sarah, whatever. I guess I have to just check it differently on the Spotify. Anyway, no, you're cool. Everything's good here. Sarah, but tell me, like, why are psychedelics so good for substance abuse? What makes it exciting? Like, tell us.
Well, actually, Ben, why don't you start that answer and I'll finish it?
Yeah. The way I like to think about it is that, Sarah and I've talked a little bit offline about just what would be the ideal situation. If you had infinity dollars to throw at the problem of addiction, what would that look like? And then try to bring those ideas back down to earth. And what psychedelic medicines hold out as a promise to us at this point is the idea of essentially hitting a bit of a reset button neurobiologically and allowing somebody to go through something closely analogous to the first 20-ish years of neurodevelopment all over again a little bit. So the idea is you go, not to get too spiritual too soon, you get reborn, you get reparented, you get relaunched, is what may be the most beneficial thing to think of analogously to how you get somebody who's, recently been in the streets there, overdosing on fentanyl and needing EMS to respond, like Sarah was talking about. How do you take somebody from, that level of suffering to fully functional and launch back into the world as, a contributing member of society, working a job, starting their own business, being, well connected and contributing meaningfully and enjoying their lives? How do you go from, zero to hero, maybe would be the way to say it. That, what would it look like then to build structures into our healthcare system that could support somebody through that? Because what we have oftentimes is problems with addiction in the household where somebody's born into, and then they just kind of grow up in whatever environment they're in, and the opportunity to get up and get out away from whatever setting they're born into is not always readily available. Like, there's a lot of obstacles. So how do we remove obstacles is a piece of that. But what psychedelics again can do is, relaunch somebody in a shorter period of time is the idea. Instead of taking 25 years to grow a brain and send it out into the world, maybe in a few months or a year's time, we can correct some of the addictive tendencies in that person's brain and then reparent, relaunch, regroup all of the need to do in order to get them out there.
I love that. To add to that, because I knew you were going to set me up well, like in terms of to answer your question a little bit, like molecularly or I guess systemically, one of the problems with addiction is that you end up over time, because it's a progressive illness, you end up with these circuits in your brain that are hardwired in this addictive cycle. And what we found in some of the research and literature is that like even one session of psychedelic assisted therapy can disrupt those patterns that have been basically cemented. It can break them up essentially, which is really exciting because it's the only, it does, it creates a neuroplastic environment, meaning that your actual structures and your neurons can change. New ones can be born, things can move around in ways that we didn't think were possible. And just like Ben said, I'm sorry, I cannot call you Doc, you're Ben. Just like you said, it is sort of, what we used to think was that your brain couldn't change past a certain age, but we're finding that these sort of open up new opportunities for it to change for the better, which also means that it could change for the worse, honestly. So they need to be done in a really safe environment. The set and setting is critically important. And that's why we've heard about really bad trips and other things. Like, there are negative consequences to not doing this safely and well, and with a practiced, licensed clinician, for example. But that said, the promise is that you can actually take someone who is uncurable and now cure them, or, get pretty damn close. It's pretty exciting.
Yeah.
The other thing, one more thing I'll just mention about like why they work really well is because some of these agents can allow you to access trauma in your past and those memories and sort of reinvestigate them from a very different perspective than you would have without. And that typically involves a lot of empathy for yourself, for other people involved in whatever the situation was. And so there's a lot of healing that can come, and it feels safer to even explore going back and exploring those types of memories. So it's using a trauma-informed approach actually works really well with these agents.
So when you said open the brain, we're not talking MRI where you're seeing anything. It's just, you're just meaning conceptually. Is that what you're referring to?
No, I actually am talking about MRI.
Okay, cool. So actually both. I mean, really both. Opening your frame, reframing how you envision or see things, and then also your brain patterns. You're actually how the neurons and how they're firing or the pathways. Can you get more into that, one of you?
Yeah, I think as much as the distinction holds between biology and psychology, that's probably a useful way of drawing the line. And biologically, yeah, you can break up connections. Like your brain is constantly doing this anyway. There's a really good book called The Angel and the Assassin by Angela Nikazawa, I think is how you pronounce her name. But it's just all about the way that the glial cells work in the brain to be both neuroprotective and to prune different locations. And that's something that's going on in your brain all of the time. Sarah could talk probably a lot more intelligently about the details there. But you can essentially unblock habit loops in terms of what the structures of the brains are within the brain, the structures within the brain. And then the psychological experience that accompanies some of what's going on in someone's brain is this opportunity to see what the relational or memory-based or contextual sources are for someone's pain, for their suffering, for their trauma, for the ways that they've developed of navigating the world based on that, the ways that they've psychologically limped through life as a result of things that have happened to them or things that they've done. They get to see what the root causes of some of that were and try to make sense of those from a place of curiosity and compassion when done with a good therapist in the safe set and setting. So you're able to reset some things in the brain itself and then reset some things in the emotional experience and the psychology of the person in a way that allows them to do the work of therapy that'll get them to be more fully themselves and whole and caring is the ideal outcome.
So when are we going to get to where Timothy Leary wanted us all to be, where not necessarily all dropping out, but I'm just like statins, where it was accessible, we could do this. I mean, I know we're very, very early on. When are we, like, it's going to be in the fluoride or it's going to be statins? I mean, is that ever going to be?
Yeah, I think it's real early in the game at this point. I mean, like MDMA and psilocybin got breakthrough therapy designations from the FDA in 2017 and 2018. And then the first NIH grant for psilocybin research was 2021, and it's only 2024. So even though you can get kratom over the counter at a gas station right now, which has some affinity for opioid receptors, I think we're still many, many years away from the Harvard rejects bunch idea of putting LSD into the water system is probably not coming back around. Yeah. Probably wasn't a great idea then, probably isn't a great idea now. But as we continue to study these things, we'll begin to be able to figure out who needs it most and how to get it to them and where the most benefits are, what the risks are, what the alternatives are. I don't know. What do you think, Sarah?
Like, is the question about
access. I mean, I was fully accessing it. Like Tylenol is
Access.
pretty accessible versus today it's not accessible at all. I mean, where am I going to get psychedelic therapy? John Hopkins, I have to enroll in a study, and good luck getting in if you're one of how many. So anyway.
Well, the easiest answer there is that, I think a lot of people actually don't know how readily available ketamine therapy is. It's in a lot of places. I actually didn't even know that we had a ketamine clinic in Spokane until literally a couple weeks ago. The problem is that it's, private pay and expensive right now, pretty much across the board. So it is, as Ben said, going to be many years before what we will need is a policy decision to start processes wherein our public insurers pay for therapy. And we also need to simultaneously build up an infrastructure for training clinicians to do this work. We already have the places where it can be done. So I think incorporating it into places like I was speaking about last night, there's a comprehensive treatment center, in Spokane, and they already have the people and they just need to be trained. So people like Doc here, I think should be in the near future paid to consult and build programs. And there will be others that can do that. But it needs to come from the top down, because we've got a lot of stigma around addiction to begin with. We've got a lot of stigma around psychedelics. And so we're trying to really reach pretty far to change the public understanding about what these things are and are doing. But you're right, Ben, we didn't have a funding for true rigorous research on this until very recently. But in 2022 is when the Journal of Neuroscience and the Society for Neuroscience started having talks on this topic. And there's a really great review article about the benefits of psychedelics for a number of different areas, and got into the weeds about mechanisms, about what it's doing for dendrites and what it's doing to gene expression, and why serotonin matters or not, and the microcircuitry and the macrocircuitry and all these changes. That actually, whether you know what I'm talking about or not, that really matters to me, because that means my scientific community has now accepted that these things need to be studied. And then that's basic science, right? And then we've got translational science and we've got clinical science that are also on board. Those three engines, they usually take 20 years, frankly, to push changes into society, though. So I think it's going to be a while. However, my only thought is ketamine clinics operating and doing this work now legally matters. Mm-hmm. I think as long as we can get the word out that that's happening and expand that first, and then move into some other things that feel a little scarier to people, that's where we need to go.
Well, I think last time we had you on, Ben, you really mentioned about ketamine with the off-label. It's been around for so long, and the power of what already exists. So hopefully, like what you're saying, Sarah, that these places can be more affordable. I know there's some startups in this space too, that might accelerate that with innovation. I would hope innovation, on the entrepreneurial spirit, and then also the research, if these groups can get together and really help people. Otherwise, 20 years, my gosh, we'll be at Mars by then.
Well, the sad but true fact is that medical education tends to lag 10 to 20 years behind medical research, just as a standard way of, being careful and cautious and vetting the research that's being done in a way that by the time we're going to say, yes, this needs to be standard of care, that all, doctors and PAs and nurse practitioners are receiving as a way of conducting this to mitigate risk and to maximize proper outcomes. That does take a certain amount of time. We don't want to rush a lot of those things, but we also don't want to wait forever. If something is, relatively safe, that should be something we can find out pretty quickly. The abuse literature that's out there would be one place, toxicology studies be another place. It seems that outside of ibogaine, which we could talk about if that's of interest, or we could, talk about some other time, the majority of the potential risks of the psychedelic substances out there. And I'm thinking of, the plant medicines, psilocybin, mescaline, DMT, ayahuasca, those, and then some of the less plant-based, more chemistry-based medicines like MDMA or ketamine. It seems that the risks there are mostly transient sorts of side effects and not long-term outcome problems, other than having psychological questions about whether they were in a safe place or had a good outcome from that. But all of the risks are non-zero compared with, fatal issues around some medicines. But we know pretty clearly at this point a lot about the safety biologically, unless you want to correct me on that, Sarah.
We know a ton.
Yeah.
They're quite safe. The harm to user score on psilocybin is like 10, and the harm to user score on heroin is like 90.
Right.
So, and they all have, there's no zero harm, of course, but they're extremely low, and they're very unlikely to result in addictive tendencies, meaning people do not get addicted to these classes of drugs in the same way that they do others, which is obviously important when you're talking about someone with a substance use disorder or are prone to that.
That's always the biggest deal, right? Is safety first. And then we start to look at how effective are these things in particular indications. And then what would it look like to roll all of that out? Again, some of that's just going to take time.
Yeah. Well, we've known they're safe for decades.
For millennia, some people would argue.
For millennia, for some of them, honestly.
Can't we hurry up?
Don't get me started on DMT, you guys. I could go on and on.
All right, go.
I think DMT might be a big answer here. Here's why. DMT is the active ingredient in ayahuasca. The only reason you can ingest it and it have an effect is because ayahuasca has two components. One of them has the DMT and one has something that allows it to pass through the gut and into the bloodstream without being broken down. It gets broken down really quickly though. And why that's good is that if you're going to do a therapy session with someone, it costs a lot of money to have someone babysit them for 5 or 6 hours. DMT is more on the 1 hour range, and then it's gone because it clears so quickly. So I think we need to investigate the effects of, longer sessions versus shorter in terms of efficacy. But that said, there are some folks that are really excited about the use of DMT because it's an injectable and it only lasts an hour and a half-ish. And then you can, your clinician can go on their merry way, basically. But I mean, if you're talking about a physician spending 5 hours with a patient, I'm sorry, that is extremely expensive. So that's going to be a major barrier for access to these compounds. But we also, let me also say, we need, a multi-pronged solution to the substance use problem, right? Like this is one tiny piece in what I think we could do which is a coordinated, integrated, multidisciplinary effort wherein someone gets everything that they need. The systems that work really well for addiction medicine, regardless of psychedelics, are the ones that have wraparound services, have transportation as a part of them, have, the appropriate level of care for the severity of the illness, whether it's, inpatient, and then transitioning someone from one sort of class of therapy, if you will, sort of inpatient to intensive outpatient. But you can't do that without making sure someone has stable housing and has food and maybe has, a purpose in life, a job or something. And so the programs that are doing really well for that are, New York State has some that are pretty good. But the country of Portugal did a really lovely job with their opioid epidemic. Went from a real big problem in the 90s when we were all hanging out in our DARE programs. And they basically eradicated it. And the reason it worked so well has nothing to do, in my opinion, with decriminalizing. Because people get all up in arms. They're like, well, they decriminalized and we tried that in Oregon and it didn't work. What actually worked was that the law enforcement was totally on board with setting up a really wonderful system of care for anyone that needed help. If anyone needed anything, they knew where to get it. And they had everything that they needed to get better. Nobody wants to be addicted and living on the streets. No one's interested in living that life. And so what they realized was that people just weren't getting what they needed. And so they wrapped around, all these different systems of care. You got a personal care attendant if you needed help that really walked, basically like your own personal social worker, and walked you through the whole system. You have all these services, and the law enforcement was totally on board and worked with the government, the private people, the industry folks, the academics, like everyone was working together on it, and their numbers are incredible.
What did they do with the purpose? Like I hear taking care of them, but at a granular level, helping, get people a purpose or job or work in Portugal. Do you know?
I don't know the details on what they would do for occupations. However, I know that they counseled them on getting them back into the workforce at their own pace.
Mm-hmm.
And, one of the issues in our country is that, a lot of our payments, are 30 days, 60 days. These were as long as you needed it. And they would work with them until they really had everything they needed, up to, I think, 14 months or so. So that's another thing, was the longevity of it. But yeah, they had counselors that would work with folks on getting them either into the workforce or trained to do a job, which is something we're exploring here in Washington as well.
Which is interesting to see what the timelines look like in Portugal without any kind of psychedelic assisted therapy going on. Again, I like to emphasize that it is a psychedelic assisted therapy and not therapy assisting psychedelics, because it's the medicines that like steal the headlines and everybody wants to hear about. Well, do you see real aliens when you take DMT? Or like, that's what all the conversations wind up being about. And like, the truth is nobody knows. And I don't think anybody will ever actually know, or whatever. But those are interesting and fun conversations that draw attention. But I think it's hard to overstate how important the therapeutic piece is. Somebody being in therapy, understanding, being on the trajectory to getting better, and then accelerating them on that trajectory is what we're talking about trying to do with psychedelics. We're not talking about just giving somebody the right prescription for the right dose and duration and frequency, like has been the typical standard of care previously. This is intended to be like an accelerant to therapy. And if we're looking at, say, Portugal as an example, on the far end, it's taking them 14 months to get somebody back to living from addiction. Maybe we could shorten that time span, is the hope that we kind of were coming together, bringing the conversations full circle. Maybe we can do it in 6 months. Maybe we can do it in 9 months. I'm the kind of guy that wants to figure out how fast we can do that junk for, but we're still a few steps away from having the opportunity to try to test that out.
It's totally feasible, though. I think, they say that, one session of psychedelic assisted therapy is equivalent to a year of talk therapy. I don't know who came up with that figure, but
they say 10 years. 10 years is the famous quote, but I think that's just from a patient. They were like, yeah, that felt like 10 years of therapy in a day. And that's something that'll go on a bumper sticker, right? So send it.
I'll take it. I think that they're actually, I can't quote you the literature, but there's something there like that. It can actually help instead of, something taking a really long time. It can accelerate the process of getting well.
So what is exciting that we're seeing, that you're working on, that you can share, that's similar to Portugal, or aspects to it, or if it was a real program, like what would it look like if you could wave your wand and make it happen, both of you? What would that look like, and what would it be?
Well, I have an idea that we're moving forward with here. Our legislation just passed a bill to build a couple of pilot houses as traditional housing facilities for people from ages 18 to 26 coming out of institutions for substance use and moving into these like transitional homes. Now, this will be different than other transitional homes. There will be clinicians on site full time. It won't sort of be a free for all. Some of the typical transitional housing is actually very not unregulated and kind of a disaster, and really actually leads to a lot of people just getting right back onto the substances that they were on before. So these will be really well cared for and well funded places. There's going to be a pilot on the east side of our state and on the west. And my colleague who is in charge of overseeing this and I have been in talks with what types of services will be available to the people living in these places. And we have a vision for piloting psychedelic assisted therapy as a part of their therapy that they're receiving there as they're moving towards an intensive outpatient program. So that's in the works. kind of process. And I have a couple other ideas that we're pitching, but the idea is that it is a part of, they'll have regular talk therapy in-house, but we would probably connect them with a clinic outside to have them receive this type of therapy. And then they have a job counseling, and a couple of other things that I was talking about. So like dealing with your social determinants of health issues will happen here because it's a place where people can land for, I think it's 60 to 90 days. I can't remember what the number is. And then they transition out. So that's what I'm working on. I'm kind of excited about it. And we'll do some research on how well it works and publish it and be super academic and rigorous about it.
Rigorous.
Yep. That's the idea.
Cool.
What's going on in Kentucky? Nothing?
Yeah, not a whole lot. There was that whole the Ibogaine initiative kind of was dead in the water here, and that was drew some national attention at one point, but it was kind of a bit of a Hail Mary pass. But I think the Ibogaine story in terms of research and as a medicine is far from over. It's just that Kentucky state funds won't be used to try to do any of that research, which really isn't that big a deal. 49 other states are also not funding Ibogaine research currently. So, it was an interesting story and an interesting time for Kentucky at that point. But I don't know what the future of psychedelic assisted therapy might hold here.
Can you share just general terms of the Ibogaine research and what that is and what the hope was and just a little background?
Yeah, Ibogaine is a plant medicine from West Africa, grows in a tree over there in a bush, and has notorious worldwide effectiveness for addictions of all kinds. I think it was the 1950s in America, it was being looked at as a prescription med, and we're always very clever with the names of brand medicines, right? So it was called Endabuse whenever they were first looking at using it, because that'll sell. And what it seems that Ibogaine is capable of doing, as distinct from virtually anything else we've been able to discover on the planet, is to crush out what is a 90-day window of sort of a danger area, a linear danger area for addiction. That first 90 days after somebody gets into treatment is when you have relapse or overdose or suicide because of the pain of withdrawal, just the suffering, the difficulty, all the problems with that. And the standard of care currently is opioid replacement of one kind or another, where you're mitigating the withdrawals as much as you possibly can while still trying to prevent relapse and just trying to help somebody kind of struggle through the window of danger there early on. It seems like Ibogaine may crush out a lot of the somatic symptoms of withdrawals in a much shorter period of time. We're talking hours to days rather than weeks to months to get through to the other side of some of that. There's a lot of corrections going on biologically in the brain that we still don't understand super well. We know some of the places that it binds and understand why that would help with things like opioid addiction or things like cocaine addiction. But there's still a lot of research needed to be done on exactly how it works, and also the safety of the medicine. It does bind to a particular potassium channel in the cardiac myocardium that usually is no bueno for a medicine to bind to, and can put somebody into ventricular fibrillation if they already have some underlying cardiac arrhythmia potential. So there's a bigger risk factor and a bigger reward factor surrounding Ibogaine that we're trying to figure more details out. It was just back in, I think, January that the journal Nature published a study that you and I talked about on my podcast, Sarah, surrounding how combining Ibogaine with magnesium may stabilize the cardiac myocardium in a way that could prevent some of that from happening. But again, a lot more research needs to be done around the safety of that medicine before anybody should go searching for it, in my opinion.
No trips to Africa yet.
Not for this guy.
Unless you got your magnesium.
Yeah, hyperdose that mag. And that's what I do anyway. Just in life, I take a lot of magnesium. So I should be fine if somebody sneaked up on me and gave me Ibogaine, but we'll see.
Yeah, we won't do that. Won't do that here.
Yeah, well, the sad thing I think is, the unavailability of some of these things that we know work. That research study that he referenced that we spoke about on his podcast was done sort of retrospectively on patients that had gone seeking this medicine in Mexico, I think was the story.
Yeah, 30 Special Operations Forces veterans with mild traumatic brain injury went down to Mexico.
Yep, and it was really effective. The stats on these things, I look at a lot of research, and you don't see numbers this good. So
yeah,
it's
at
pretty...
30 days, it was like 86% were in remission as far as their post-traumatic stress disorder goes, 83% remission from depression, 83% remission from anxiety, cut, cravings for things like alcohol and heroin and cocaine in half. And you don't see that in anything else out there, right?
Yep.
And so you can get this in Mexico too?
Yeah, it's legal in Mexico and New Zealand, I think.
Oh, okay.
Are two of the countries. Yeah.
But it grows mainly in Mexico, mainly in Africa, is what you're saying. It's okay.
Yeah. The only place it grows naturally on the planet that we've been able to find it so far is in West Africa. I think it's Ghana. The Bwiti tribe is famous for that's their sacred plant, sacred medicine. If people are interested, they say that like the trip journey stories around it are pretty crazy for sure. They call it like being in a room with a compassionate gorilla. You know that this thing could destroy you anytime that it wants to, but it's just here to help. It just wants to help.
Sounds like my wife. She means well, man. I don't mess with her, man. She's a loving gorilla.
The compassionate gorilla. That's not going to get you any points at home.
She doesn't listen to my podcast, so I'm okay, right? Every week I throw in a little wing, like one of those drops, just to see if she's listening.
Just to see if she.
Yeah.
And she's just storing them all up.
Yeah.
And she'll let you know at one point. Yeah.
That's great.
Yeah. I was just meaning metaphorically, all right?
Me too. Yeah, there's no actual gorillas associated with taking ibogaine. They do call it, the PhD of psychedelics out there, for what that's worth.
Well,
why do they call it that?
I think it's supposed to give you the big picture view more reliably than a lot of other medicines. So they say, like, this is the one where you might see God face to face, and he, she, they, them, whatever you want to call it, shows you the universe and why it is the way that it is. And whether you'll ever be able to articulate that meaningfully or not, that reliably happens over and over again, people.
Wow.
There's also this, what do they call it? Like a slide deck experience of your own life that tends to be a part of the trip reports with ibogaine, where somebody gets like sat down on the couch in their living room when they were a kid, and then they watch the movie of their life as if it was all over, but it's not actually all over. They're like, all right, so now I understand why I'm screwed up in the ways that I'm screwed up, and I can be different. I feel like I can be different. What's next? And then you go see God, and God says, this is what the multiverse looks like. And then you get set back down into this tiny little hangnail of a body compared to everything else that's going on there, and you get to try to put the pieces back together again and figure out where you go from here.
Doc, this is why you are called Doc, and you need to come on again. I'm telling you, man, you are the compassionate gorilla.
I've been called worse, for sure.
Dude, you're amazing.
I think that's what people called him in college.
What did they call you?
Something close to the compassionate gorilla.
I think it was just asshole words most of the time, but
no, it was like terrifying, but surprisingly friendly.
Yeah.
The claws retract.
Yeah.
He could kill me, but I don't think he will.
Yeah.
He just wants to play.
I love it. I love it. Well, Sarah, come on. You got to reply back. You got a doctorate too. Come on. You got super smart people here today with all things psychedelic.
Well, that's nice of you. Yeah, I think I'm compelled to think that these it's almost like a lot of the research I've been looking at, they'll study the direct effects of these things on substance use disorder, but sometimes it's like a side effect oh, they just stopped drinking or they stopped using, drugs. Like the ayahuasca literature shows that over and over again. Like people that have done ayahuasca retreats or are regularly participating in those activities just, aren't using substances when they used to, maybe not even abusing them, but, like a lot of those folks are just, don't really do that anymore. And there's a reason for that mechanistically in the brain. And we just are finding it out. We don't even really understand it very well. On a molecular level and on a macro like circuitry systems level. So I think that, since we're finding that that's the case and we know in direct studies that it's effective, it should be a tool that we are allowed to have in our tool belt to provide comprehensive care for people suffering for these, with these, I'll call them illnesses. It to me is sort of mind boggling that something that effective is still like, so scary that Kentucky won't touch it with a 10-foot pole. I think policy is where I would like to see change happen. Really, the places that have done it really well are because it was prioritized and well funded at the government level, as much as some of my private organization people don't like to hear that. I think that that's probably one of the best solutions that we'll find, and perhaps it'll be like a federalism extravaganza, like state by state, or we'll have one state that really takes this on and does it so well that that'll be the national example, and then it will be federal. That happens almost all the time too. So
what's the state? Colorado, New Mexico, California?
Well, Oregon just sent a massive delegation over to Portugal after their decriminalization experiment failed with flying colors. They're interested in implementing it. They tried sort of a baby version of it when they decriminalized all drugs back in just a couple of years ago, right? The rollout had attached to it a county-based system that, like we were talking about, almost like what Portugal had. Like, okay, we need to provide services for people if we're going to decriminalize drugs and we're going to have problems, and we need to provide services for people that are suffering from substance use disorder. They were underfunded and they were done at a county level, and they didn't integrate all of the different levels of care together and provide proper transitioning from one level of care to another, just like I was talking about. And so they were like, what did we do wrong? They kind of tried, but then they sent people from all different levels of government, academia, like different stakeholders went over to Portugal. This is really just recently, and they wrote up a full report of what they did wrong and what they would do, in the future. If they decide to fund it and do something like that, then it could work. But they said it needs to be at the state level, not at the county level.
It seems like the ROI, I hate the word ROI, but geez, if you really were serious, the ROI would be exponential on this funding with, just doing it at one point to see it. I mean, the amount of deaths, if you really total up all the costs, it's astronomical. With that, it's just needs to be, the will. It's the everything's there.
I have you mentioned the decrim in Oregon again, and I have several friends that are ER physicians out there, and their 2 cents on this anyway was that the reason that decriminalization failed in Oregon was primarily because of problems that were centrally located in Portland. And it was that after decriminalization, lots of people moved there and overdosed and essentially overwhelmed the system. It was still just an opioid primarily problem in Portland that they were not prepared to navigate. It wasn't as though a whole bunch of people moved to Oregon to take mushrooms and start a commune or something like that out there. It was, again, just a snapshot giving us an example of how bad the opioid crisis can get in response to an infrastructure that's not prepared for the level of overdose that would take place after you pass that sort of legislation. So, and Oregon's just, they're doing interesting things there for sure. I was just talking the other night to the owner of one of the largest approved licensed psilocybin treatment facilities out there about what's it been like, they rolled out and they've done about 400 psilocybin assisted therapy sessions in a very short period of time. And this guy is one of the owners. He's going to come on my podcast here in a couple of weeks. The company, I think, is called Satya Therapeutics. His name's Andreas Met. And he was just saying, I think people are going to be surprised by how much work it is to do psychedelic assisted therapy, where, Sarah, you were saying like 5 hours is on the short end of things for a psilocybin journey. An ibogaine journey can last 24 to 36 hours. Like, there's a lot of infrastructure around a person who's taken a psychedelic journey that we haven't exactly figured out how to facilitate that yet well, but they're kind of the canary in the coal mine, one of the larger facilities out there. And it's going to be pretty interesting to see what exactly that looks like as things progress. Who's going to be the leader? Kentucky took a knee. Who wants to be the leader out there?
Kentucky was never going to be the leader.
Man, we'll surprise you sometimes. We're pretty good at basketball anyway.
It's a bourbon or whiskey, both, right?
Right. Yeah, we got problems.
And healthcare. You got healthcare. A lot of healthcare there.
Yep.
Companies, at least, right?
Horses.
We do have horses. Yeah. A lot of farms. Nice farms for sure. A lot of good people here.
Well, we're kind of wrapping it up. You guys I really appreciate you guys coming on and really opening up our minds, no pun intended, to this psychedelic assisted therapy, really helping, if we can get the public health infrastructure, the model, really tackle addiction medicine.
Yeah. I think we can get there. It just might take some time.
All right. Well, any last ahas?
I'm just going to self-promote for a second.
Please do.
I don't have a self, but I'm going to promote it anyway. If you are in the Louisville, Kentucky area and you want some psychiatric help, I have a private practice here. You can reach me at advancedpracticeproviders.com and I'll see if I can help you out. And if you want to buy my book, it's at antiheroesjourney.com. Also, I have a podcast where Sarah and I hang out and tell psychedelic science war stories from time to time.
It's super fun. And sometimes we talk science.
Cool. This has been great. I definitely need to read your book, but I have to buy it first. So I need to buy it first and then read it. I'm excited. And
you can pirate it. I really don't give a shit.
No. Every time I have you on, I learn so much. So anyway, I know your book was a passion, not necessarily, I said like a messiah, like you said, but something like a Handle Messiah, where it just came just like, I guess, over 2 weeks or so. I don't know. Anyway, I'm now digressing because I just said we're wrapping it up. I'm sorry.
Oh, it's fine. It's actually a channeled work from the Archangel Michael. I'm just kidding. It's from the Anunnaki. It's from the
It's from the Starbucks tribe.
It's absolute garbage. You should use it as a coaster.
Yeah.
It's bonkers. It's a real journey. Read it. It's great.
It's fun.
Awesome. Well, until next time on Planetary Health First, Mars Next. This has been great on Bring a Friend, and we've had some really good friends that have known each other for 20 years go through all things and everything. This has been great to have you, Ben and Sarah, on today. Until next time.